Sir.
Sandhamini. Sandhamini, again, today I'm squeezing you into 2 meetings. So can we just listen to the summary of the history and the examination? I'm sorry, I won't be able to listen to the whole history today. We just listen to the summary and then I'll discuss the case. Okay?
Okay, sir.
Right.
67-year-old, a known patient with COPD for 10 years and a smoker with 45 pack years, presented with acute onset shortness of breath for 2 days, which has worsened over time. He had productive cough with whitish sputum with generalized body weakness, but he had no fever. He has exertional dyspnea, no orthopnea, paroxysmal nocturnal dyspnea or chest pain. He was on 2 inhalers, preventer the budesonide and reliever salbutamol inhaler with poor compliance and wrong inhaler technique. He had stopped his preventer inhaler for the last 2 weeks duration. On examination, he was dyspneic. He had barrel chest with apical flattening, intercostal recessions, and sternal recession, substernal recession. Chest expansion was equal and adequate. Percussion note was increased, and he had bilateral bronchi on all 3 lobes.
Okay, right. That's fine. Thank you. Hari. Now, again, COPD. So let's talk about COPD and then discuss about purely about the management of COPD today. But just to revise a little bit of stuff that we've been doing before, right? So a little bit of a background to the diagnosis. Diagnose COPD. That's the first important thing, and you can be asked this at various points, right? First, if the patient is not a diagnosed patient, you might be asked sort of how you establish a diagnosis of COPD. Right? So let's talk about that first. Right, now COPD is a bit of a dodgy diagnosis. The main reason is COPD is an umbrella term, right? It is an umbrella term which includes various components. So under that big umbrella term of COPD, it actually includes various components. Right, what are the components? Number one, within that umbrella of COPD, you have emphysema. Now, emphysema is purely a pathological diagnosis, which essentially says that there is destruction of the air passages, destruction and actually dilatation of the air passages distal to the terminal bronchioles, right? So that is what you mean by emphysema. Dilatation of the air passages distal to the terminal bronchioles. That's what it means. Okay. So under that big umbrella term of COPD, you have emphysema, right? Then under that umbrella, you also have chronic bronchitis. Now, chronic bronchitis is more of a clinical definition where the patient develops bronchitis, sort of symptoms of infection several times in a year, right? There is a standard definition for that, but don't worry about that. So chronic bronchitis is more of a clinical definition where they develop chest infections with sputum production several times of the year. That is chronic bronchitis. And also they have small airways disease, right, as well within that umbrella, right? So they have a small airways disease, quite similar to asthma, but as you know, the reversibility is not very good of that air. So small airways obstruction, which is not very reversible like in asthma. So within that umbrella term, you have these 3 things. That is COPD, right? So that is a sort of definition of COPD, or that what it includes. So how do we diagnose COPD actually? So you start off with the history and examination, right? And remember, අර කියපු දේවල් mixtures තියෙන්න පුළුවන් එක එක ඒවා, right? So emphysema, COPD, and a small airways disease. So you can have a mixture of all these things, right? So when you come to the diagnosis, so there will be history and examination. We talked about this during the discussion on Shortness of breath, අපි කතා කරා නේද? How you diagnose in the history and examination, how you diagnose COPD, right? So you have the history and the examination and investigations, right? Investigations. You will see number one, an obstructive pattern on lung function test. When you have a COPD patient, you have obstructive pattern on lung function test. And additional to that, you can look at airway reversibility in the lung function test, right? So you can give them a bronchodilator and see if that airway reversibility is there, right? So by definition, the reversibility is less than 12% in COPD, right? Reversibility, airway obstruction reversibility is less than 12%. And you can do that. Bronchodilator, you redo the lung function test. So history examination, lung function test showing an obstructive pattern, and the obstructive pattern is poorly reversible post bronchodilator, right? So obstructive pattern is poorly reversible post bronchodilator, right? Okay, so those are the investigations. And in addition, you might be able to see features of emphysema on a chest X-ray or sometimes a CT scan, right? So you might be able to see that sort of additional information for the diagnosis, right? Now, so history, examination, and investigations will sort of make a diagnosis of COPD. So history, examination, we talked about this. So smoking as a risk factor, shortness of breath, then features of hyperinflation of examination of and then on top of that, now we have investigations to add on, right? So obstructive airways disease, which is poorly reversible post bronchodilator, that is important. To use the proper definition, it's less than 12% reversibility. And then finally, you have that added evidence of emphysema. You can see emphysema on the CT scan quite clearly if you do a high resolution CT scan. And of course, on the X-ray, you will see these. When you have emphysema, the lungs are hyperinflated. So you will see all of that in the X-ray as well. Right. Any questions about that diagnosis again? Right. Okay. Now, the management of COPD is very straightforward, so we can quickly go through that, right? First of all, now in this sort of case, the first thing that you're going to be asked in the exam is how you manage an acute exacerbation of COPD. Now, we'll talk about this a little bit more in detail when we do acute medicine discussions next week, but we can take a start on it today. Right. So just go through the principles. Right. So when you have a patient with an acute exacerbation of COPD, it's important to keep in mind that the patient give how do you manage an acute exacerbation? Right. They come in, usually these are infection driven. So that is an important point to remember. Right? Usually these acute exacerbations are infection driven, important to remember. Right. So patient comes into hospital, it is an emergency. So A, B, C, D, E approach as usual. Right? And then the next important point is you have to be very careful about the amount of oxygen you give them, right? So that is very important. Write that down. Be careful about the amount of oxygen you give them. This is especially because, and write this down clearly, right? This is especially because okay, so this is especially because COPD can give rise to long-term CO2 retention, right? That is a problem. So you have to be careful with the oxygen when there is CO2 retention. Now, why is this? Why is this? Right? You might already know the reason. Now, usually our respiratory in COPD. Because of that, the brain loses its response to CO2. Then CO2, right? CO2 ganangan. And it is actually the hypoxia that drives the breathing now. In a normal person, it is the CO2 that drives the breathing. The CO2 level drives the breathing. But when their CO2 levels are high for a long time, they get used to it, right? And they lose their respiratory drive due to CO2. So in those people, hypoxia is the only thing that maintains the respiration, right? Respiratory effort and rate and all of that. So if you are not careful, if you overcorrect the hypoxia, they'll stop breathing, right? That is very important. Clinically also, සමහරවිට අපි ඔක දකිනවා. ලෙඩෙක් එනවා COPD exacerbation, you give them oxygen. විනාඩි 5ක් විතර ලෙඩා හුස්ම ගන්න respiratory rate එක අඩු වෙනවා, ලෙඩා becomes confused and drowsy. That is very important. ඔක අපි best response MCQ වලත් ඔයගොල්ලෝගෙන් අහනවා. MCQ එක පැත්තකින් තියන වාට්ටුවේ this is an important observation, right? කමින් ඔක්සිජන් ටිකක් දීපු ගමන් එකපාරට හුස්ම ගන්න නතර වෙනවා, right? So that is why you have to be very careful when you are managing the hypoxia. So as a general rule, as a general rule, if your patient has evidence of CO2 retention, long-term CO2 retention, the target saturation you should maintain is 88 to 92%. That is your target saturation level. And you can use Venturi mass Saraka to maintain that target saturation. The over කියපු ගමන්ම ප්‍රශ්නයක් අහනවා. ඉතින් අපි කොහොමද දන්නේ ලෙඩා CO2 retain කෙනෙක්ද නැද්ද කියලා දන්නේ කොහොමද? Right? So you might ask me, right, then how do I know whether the patient that walks into my casualty is a CO2 retain or not? So quickly go through the clinic books. They might have blood gases when they were admitted before that you can go by. එහෙම නැත්නම් ඉතින් බබා trial and error තමයි. Right? So you have to be careful with the oxygen in general. Right? පරිස්සමෙන් බලන්න. But most of the time these patients නිතර එනවනේ. When the oxygen levels are due, the carbon you do blood gases in this river. So they have the old records. You can see this guy is a CO2 retained. I have to be careful with the oxygen levels. So 88 to 92% is a usual reasonable saturation target. Okay. Any questions about that principle?
So in COPD patient, can we take flapping tremors which can be occurred due to carbon dioxide retention as an indicator for our oxygen supplementation?
Sorry?
There will be flapping tremors in patients with carbon dioxide retention. Can we take that as an indicator to find whether he's on long-term carbon dioxide retention?
It's difficult, but even if it's acute carbon dioxide retention, you still have flapping tremors. හරිද? ඒතර අමාරුයි, but you can judge නේ. හිතන්න පුළුවන්. Reasonable, but acute තිබ්බත් එනවා, but that is a reasonable clue. ඔය එකපාරට CO2 retention එනවා මේ COPD එකේ තියෙනවා කාලයක් තිස්සේ ඔක තියෙනවා, right? So it's a clue, but it doesn't definitely prove that there is chronic CO2 retention. හරි? Clue එකක් එක definitely. Okay?
Yes, sir. Thank you.
Right. So be careful with the oxygen. If they have CO2 retention, be careful. And be careful. 88 to 92 is fine. Right. Then, of course, once you get this oxygen thing sorted out, nebulization is important, and we commonly use combinations of ipratropium and salbutamol and NEPs. Right? That is a useful thing to do. Okay, fine. Right. So nebulize them. So give them the controlled oxygen, nebulize them. Right. That is important. So we usually use combinations of ipratropium and salbutamol. Right. Then the next thing to do is, once you have started nebulizing them, steroids. Right. Steroids. Now there is a bit of a new thing that has come up over the last year or so, that steroids are mostly effective in COPD patients who have a relatively higher eosinophil count කියලා. ඒක පොඩ්ඩක් පැත්තකින් ලියා ගන්න. ඕක දැම්මම අපේ කට්ටියට කියන්න යන්න එපා. Obviously people like Professor Shamford and the general physicians will know about this, but not the specialist. But there is a new thing that has come up over the last few years. අපි හැමෝටම steroid දෙනවට වැඩිය now we know that in COPD steroid responsiveness is determined by the eosinophil count කියලා. ඒක පොඩ්ඩක් බරහන් ඇතුලේ ලියා ගන්න. මේ දැනට ලංකාවේ හැමෝටම steroid දෙනවා. හරි COPD exacerbation we give steroid to everybody. But over the last few years there has been a change in that management overall in the world, because now we know that steroid හොඳ in a certain proportion of people who have a higher eosinophil count. Right. Now, apart from that, so oxygen nebulization, steroids, antibiotics. So, as I told you, these exacerbations are most often due to infections. So, ENISA, you have so you have antibiotics added on to the management. You can use anything. Coamoxiclav is a reasonable choice, right? Coamoxiclav is a reasonable choice. The only thing you have to be careful of is sometimes COPD patients have pseudomonal infections, right? Repeated sort of pseudomonal infections. එතකොට pseudomonal infections තියන අයට we usually give them ceftazidime, right? Or other anti-pseudomonal medications. Hari. So ඒක හරිනේ. That is also clear, clarified. Right. Now the next thing I want to tell you is, so you're treating your COPD patient, you're giving them oxygen, you're giving them nebulizations, and now you're sort of steroids, antibiotics, now you're sort of managing the situation. You watch for about 1 hour, right? So 1 hour from admission, you start the management in the first 5-10 minutes, watch about 1 hour. If your patient is not improving, there are certain things that you need to do. One is a blood gas, essentially, you have to do. Chest X-ray is another thing that you have to do, but you usually කොහොමදත් කරනවා chest X-ray එක. කොහොමදත් කරනවා. But you have to review the findings of the chest X-ray and do a blood gas. Now this blood gas is a very, very important thing. එතන තරුවක් දාන්න ඒක ලියා ගන්න. In the blood gas, you are looking for evidence of type 2 respiratory failure. You are looking for evidence of type 2 respiratory failure. So you start off your patient with sort of initial management, and within 1 hour, if the patient is not improving, do a blood gas. If that shows type 2 respiratory failure, you have to give the patient non-invasive ventilation. That is very important, and that saves lives and improves outcomes. Right? So you have to give them. If there is evidence of type 2 respiratory failure on the ABG, you have to start them on non-invasive ventilation, and there are various modes of non-invasive ventilation. For COPD, the best one is BiPAP. That is too much for you, but BiPAP is the recommended mode, and that is clearly proven to improve outcomes. Right. Why you do the chest X-ray is because you can see things like pneumothorax, because COPD patients, especially when they have emphysema, their lungs are full of air and they sort of blow apart the cadeno. Right, so that might cause problems. Okay, so they might cause pneumothoraces. Okay, right. Any questions up to now? So that is how you manage an infective exacerbation of COPD.
Sir?
Yeah, so steroids then, it's prednisolone 30 milligrams. That's the usual dose. Yeah. Hari. Okay. Right, so that is the management of an acute exacerbation. Right, now let's imagine you have treated the patient's acute exacerbation. Now we are moving on to long-term management. So let's talk about the long-term management of COPD. Right. Long-term management of COPD. Okay. What a sorry. Right. Okay. Right. Now, the long-term management of COPD, again, there are certain principles. Right. Number one, stop smoking. That is very, very important. By stopping smoking, you cannot reverse the pathology, but you can limit the pathology. So, Lilangi, about all these nebulizers and things, we'll talk in more detail when we're doing the acute medicine scenario, so it will be better. Right? Doses and I'm just doing the principles in this talk. Right. So now so in long-term management, stopping smoking is very important, right? That is important. And any other environmental exposures that might lead to COPD. Now remember, it's not only smoking that causes COPD, even exposure to biomass fuels, right? So yes, so limit whatever risk exposure there is, stop smoking. That is very important. And of course, educate the patient about the disease, right? The next thing is, what sort of inhalers should you use, right? That is a long term. What are the inhalers that you should be using, right? Now, again, I want you to write down the principle here. The choice of inhalers in COPD depends on two important things, right? Two important things, right? Actually, three important things. One is the severity of the COPD, number one. Severity of the COPD, right? So how bad it is. And how you measure that is by using the FEV1 FVC ratio, right? That is how you measure the severity of COPD, right? If you are interested, this is called the gold classification, Rattaran capital gold classification, right? So that is using the FEV1 FVC level. So that decides your treatment to a certain extent. And then the second thing is how much sort of the functional limitations of COPD, right? Functional limitation scores, right? Now, like the New York Heart Association score for heart failure, there are very similar scores which are used for COPD. One commonly used one is the MMRC, right? MMRC score, again, like the New York Heart Association, it gives a functional quantification to symptoms in COPD, right? Can මෙයාට කොච්චර දුර ඇවිදින්න පුළුවන්ද ගෙදර වැඩ කරගන්න පුළුවන්ද ඇඳින්න බහින්න පුළුවන්ද නාන්න පුළුවන්ද ඒ වගේ. So that is more functional score. MMRC, I think there's one more called CAT or something as well. CAT කියලා එකක් තියෙනවා. MMRC, these are all sort of functional assessment scores. Functional assessment scores වගේ. Right. Third thing is how many exacerbations and how bad the exacerbations have been. How bad the exacerbations, how severe the exacerbations, and how many exacerbations the patient has had. Right? How many exacerbations the patient has had. Right? So that is important. And there is actually now one more element which is new, right? So one is the severity of the COPD cure based on this, the gold classification. Second, what is the functional limitation of the COPD, and that is MMRC or CAT score. Third thing is how many exacerbations, how bad the exacerbations. So patient hospital, were they admitted to ICU, were they intubated, were they given in non-invasive ventilation, right? That. And then the last one is the eosinophil count, right? The eosinophil count has also become an important player when you're deciding inhalers, right? Inhalers. Right. Now, this whole inhaler COPD business is very complicated. I'm just going to give you some very basic things only, right? If you're interested, මුළු guideline එකක්ම තියෙනවා, gold guideline කියලා. ඒකේ ඔය කතන්දර ටික ඔක්කොම තියෙනවා. හරි? But I just tell you the basics. At the very simple, mild form of COPD, mildest form of COPD, right? No exacerbations, limitations, if you're an FVC ratio is also good. That is a sort of mild COPD. Okay? Just using a salbutamol inhaler is okay, right? When required. හැබැයි එහෙම ලෙඩු හරි අඩු. ඒක එහෙම ලෙඩු හරිම අඩු. Right? නිකම් මේකෙන් බේරෙන්න පුළුවන් ලෙඩු හරිම අඩු. So mild. Right? Most people are at the other end of the spectrum. Right? So at the other end of the spectrum, more sort of severe COPD, the basic principle is when make one, if they have a lot of day-to-day symptoms and functional limitation due to the day-to-day symptoms, you have to put them on a LABA, right? They have to be on a LABA. So they have lots of daily symptoms and they have lots of functional limitation. Functional limitation. You have to give them a LABA, right? LABA, right? And that helps quite a lot with their day-to-day symptoms, right? If the LABA does not work, add in something called a LAMA. LAMA is long-acting muscarinic antagonist. Example is tiotropium. Tiotropium. LABA is salmeterol, eformeterol, right? So LABA. So LABA, if they have daily symptoms, first line drug is LABA, and then add on a LAMA if that doesn't work. If they have exacerbation, if they have several exacerbations and these exacerbations are bad exacerbations, you have to put them on a LAMA, right? Long acting, but that is the best sort of option for that. LAMA. Okay, right. Last one. If they are on a LABA and a LAMA, response is not very good, and their eosinophil count is above a certain threshold, usually it's 0.3 or 300, then add in a steroid inhaler, right? Then, so remember the steroid now is linked in COPD with the eosinophil count, because we know now that the steroids work best when the eosinophil counts are above a certain level, right? So that is that. So, right? But at an undergraduate level, I think this is enough for you, right? So basic principle, mild form of COPD. The FU1 FVC is not very bad. They don't have any exacerbations and their sort of daily status is okay. Salbutamol inhaler when required. But if patient are doing the most severe forms of COPD, the choice is you have LABA, LAMA, and steroid. LABA is very good for day-to-day symptoms and functional day-to-day limitation, right? That is there. And then you have LAMAs mostly for add-on therapy, plus if there are exacerbations, that is quite good. And then steroids, if they have high eosinophil count and they don't respond to their initial medication, steroid. ගොඩක් වෙලාවට ඔය තුනම දෙන්න වෙන වෙලාවල් තියෙනවා, and there are now combined inhalers with all three also. තුනම තියෙන ඒවත්. And always remember the patient can use a sort of when required short-acting beta agonist also, right? Okay. මම කියවගේ මේක පොඩ්ඩක් මීට වැඩිය complicated, but that is reasonably enough for you as an undergraduate. Right. So when you're in the long-term management, then stopping smoking is important and risk factor modification is important and putting them on an inhaler is important, right? And proper inhaler combination. සඳමිනි මේ ලෙඩාවේ මොනවද ගන්න inhaler? So LABA එකක් ගන්නවද?
Ivasan, budesonide and salbutamol.
Budesonide, so steroid inhaler. Yeah.
Yes.
So,
Sir.
එතකොට ඒක හරි management එකක් නෙවෙයි ඇත්තටම. So I'm just teaching you the ideal currently recommended management. ලංකාවේ කරන විදිහ එච්චරම හරි නැහැ. ඒ හරි නැති වෙන්නේ හේතුව මොකද්ද? අපිට ඔය ලාම වැඩිය government sector එකේ නැහැ තියෙනවා. but වැඩිය නැහැ. ලාභත් අමාරුයි. අපිට තියෙන හොඳම දේ steroid එකයි short acting කයින ඕන තරම් තියෙනවා. but ලාම inhalers free ගන්න අමාරුයි. especially ලාම නැහැ. එතකොට යා අමාරුයි manage කරන්න පොතේ විදිහට. but ඔගොල්ලෝ exam එකට යනකොට දැනගන්න පොතේ විදිහ. so mild එක මෙහෙමයි severe එකට ලාම ICS දෙන විදිය මම ඉගෙනගන්නවා. හරි? that is fine. And always remember, with every inhaler, you have to teach exam. This is one of the frequent reasons why they have exacerbations, like Sandhavini highlighted in this patient, right? Teach them technique properly. Up to one vela vibhagedi ahanna puluwan technique එක කියන්න කියලා කියන්න පුළුවන්. You should know. And when you're practicing also, that is important, obviously. Technique, check the technique, teach them the technique. All of that needs to be reinforced. And make sure you're using the proper inhaler device, right? Some people need a spacer. Various inhaler devices. So you need to know all about that. So that is quite important, right? So stopping smoking, inhalers. Right? Now there are some other important things also. Smoking, lifestyle modification, inhale, long-term oxygen therapy, COP, long-term oxygen therapy. Right. So some people who have COPD and have long-standing hypoxia, right? Long-standing hypoxia or hypoxia and right heart failure combination it is now shown that long-term oxygen therapy, right? Usually given more than, I think the cutoff is 13 hours or so per day, right? Improves outcomes, right? So people who have long-term hypoxia, if they've demonstrated long-term hypoxia and they are or they have right heart failure and hypoxia. Cutoffs එක චුට්ටක් වෙනස්. Again මෙයා පොඩ්ඩක් කියවලා බලන්න. ඒක උගලන්ට තේරෙයි මේ කියන මොකද්ද කියලා. So basic principle is hypoxia, heart failure, right heart failure as due to COPD. They should be put on long-term oxygen therapy. That is an important principle. And that improves outcomes. It is actually one of the few things that improves mortality in COPD. Very few things that improves mortality. Long-term oxygen therapy. MCQ වලට අහන්න පුළුවන්. Right. Long-term oxygen therapy. ඊගාව කාරණේ. So අපි දැන් කිව්වා lifestyle modifications, stopping smoking, inhalers, then long-term oxygen therapy. ඊගාව එක antibiotic prophylaxis. Antibiotic prophylaxis. And general infection prevention. ඒක ලියා ගන්න හැම. Antibiotic prophylaxis and general infection prevention. Right. Okay, general infection prevention. Okay, antibiotic prophylaxis and general infection prevention. Right. Now, infection prevention, remember you have to reduce the incidence of respiratory tract infections in COPD. That is important. So one way you can do this is just give vaccinations. And remember, vaccinate them against pneumococcus, influenza, hemophilus, right? There are vaccines available. Give them the vaccines, right? Vaccine then. Then the next thing to do is consider antibiotic prophylaxis in some people, right? So people who have had repeated chest infections, right? Very bad repeated chest infections. A consultant, and remember, consultant might decide to put them on prophylactic antibiotics. A commonly used antibiotic is azithromycin. Make a හැමෝටම දෙන්නේ නැහැ. Selected patients who have had recurrent chest infections, right? And very bad chest infection needing hospital admission, ICU admission, you can consider that. Right. Okay, so that is about the long-term management of COPD. Simple. Smoking නවත්තන්න ඕනේ, lifestyle modification කරන්න ඕනේ, and then you have this inhaler therapy, and then you have this sort of oxygen and antibiotic. අන්තිමටම කියන්න ඕන දෙයක් තියෙනවා, මේක ලංකාවේ එච්චරම හොඳට කෙරෙන්නේ නැහැ, but something that should be done. Try to get them into a pulmonary rehabilitation program. Right? That is another thing. ලංකාවේ එච්චරම කෙරෙන්නේ නැති නිසා මම ඒක කිව්වේ නැහැ, but it is now recognized as one of the most important things you can do for COPD people. Pulmonary rehabilitation. So there are very organized programs. Okay, exercises, they educate them about smoking cessation, diet, exercises to improve their breathing, right? So lots of things, physio, program pulmonary rehab, stroke rehab pulmonary rehabilitation. But as far as I know, ලංකාවේ එච්චරම organized විදිහට ඕක කරන්නේ නැහැ. Right. Any questions about COP? It's not a very long thing, but obviously you can get long case, and these same concepts can be in the short case discussions also, right? Or acute medicine discussions.
So is there a place for oral medications such as corticosteroids or pills?
Long term, no. Unless, of course, definitely not in routine practice. Long term steroids COPD. Asthma වලට සමහර වෙලාවට දෙනවා, ඒත් ගොඩක් බෑඩ් ඒවට විතරයි. Control
Yes, thank you.
Yeah. Right. Okay. So Naveen, now we have to do SLD. Yeah. Can we find one for tomorrow? Patient connected.
Yes, sir. There is a patient.
Right. So let's do that tomorrow. Anything else we have left out that you suddenly remembered? When it comes to management or anything that any long cases, we're going to finish the long cases from tomorrow. If there's anything left, we can do it over the weekend because if there's anything else that you want. So then
Okay,
next
sir.
week is going to be emergencies and a little bit more polishing on short cases.
Okay, sir. The GBS also.
Let's see. It's not a major thing, but we can talk about it.
The chest pain, sir. Ischemic heart disease with the emergency.
We will do mostly in emergencies. Chest pain, nothing much
Okay,
to talk about long term. Long case, we'll ask you about emergency management, even in the long case, and a little bit of follow up care, right? Nothing much there. Right. Okay, I think we've covered everything. So we've done quite well last week. So tomorrow is SLD. And then last week will be acute medicine. And then we talk a little bit about short cases. And then we go last week, 8th week, okay, Mula, we'll do the OSCE class. Right? And that will be it.
okay, sir.
Okay. Right.
Okay.
Hi. I will see you tomorrow then, right?
Okay, sir. Thank you, sir.
Okay, bye.
Thank
bye.
you, sir.
Right, bye.
Thank you, sir.
See you tomorrow.
Thank you.